welcome back for another deep dive. Today we're going to be looking at HIV and its impact on hormones.
Interesting topic.
Yeah, it should be pretty fascinating. We're specifically going to be talking about pituitary and adrenal gland dysfunction.
Okay.
We've got some excerpts from a pretty dense academic text called Pituitary and Adrenal Gland Dysfunction in HIV-infected Patients.
Etchy title.
Yeah, very catchy. So we'll try to break that down and make it understandable for everybody. Most people, I think, when they think about HIV and AIDS, they think about the impact on the immune system.
Right.
But HIV can also wreak havoc on your hormones in some pretty unexpected ways.
Yeah, definitely. And it's really important to understand these complications. Even in today's age of potent antiretroviral therapy or ART, HIV can still have some lasting effects on these crucial glands.
Right. So even with effective treatment, these are things that we need to be thinking about. So let's start with the basics. How do doctors even diagnose and treat these hormonal issues in patients who are HIV positive?
Well, the approach is generally similar to what we would do in patients who don't have HIV.
Okay.
But there are some key HIV-specific factors that we have to take into account.
Like what?
Well, for instance, some of the hormonal changes that we see in HIV patients are actually what we call adaptive.
Adaptive.
Yeah, so it means that the body is actually trying to adjust and compensate for the infection.
Oh, so it's not necessarily a bad thing.
Exactly, yeah.
Yes.
It's not always a sign that something is wrong. Another tricky thing is that the symptoms of these hormonal issues can be pretty nonspecific.
Yeah, so that makes it hard to know what's actually going on.
Right. And to make things even more complicated, some medications used to treat HIV, or even some of its complications, can actually cause hormonal problems themselves.
Oh, wow. So you almost have to be like a detective to untangle all of that.
Yeah, it can be quite a challenge.
Before we get into the specifics of each gland, I'm curious, were these types of glandular issues more common before effective HIV treatment was available?
Yeah, you're absolutely right. Back in the pre-ART era, before we had those life-saving medications, opportunistic infections and even some malignancies could directly infect the pituitary and adrenal glands.
Wow.
So that was a much bigger problem back then.
Right.
Thankfully, it's less common now, but it's still something that we need to be aware of.
Right, so it's on the radar. So let's talk about the pituitary gland specifically. How does HIV affect its function?
Well, the pituitary is a really interesting gland. It's actually divided into two parts, the anterior pituitary and the posterior pituitary.
Okay.
Now, the anterior pituitary, which is the front part, usually functions pretty well in HIV patients.
Oh, that's good.
Yeah, but it's the posterior pituitary, which is the back part, that tends to get hit a little harder.
Interesting.
For example, a condition called hypogonadotropic hypogonadism is fairly common in folks with AIDS.
Okay, and remind me what that is again?
Basically, it means that the body isn't producing enough sex hormones, like testosterone or estrogen, because of a problem with signals coming from the brain. So even though the pituitary gland itself might be okay, the issue is actually stemming from the hypothalamus, which is part of the brain that controls the pituitary.
It's like a communication breakdown.
Exactly. And this can have a big impact on patients because low sex hormones can affect their mood, their energy levels, bone health, and of course, their sexual function.
Wow, so it's a lot more than just reproductive health.
Right.
What about prolactin? I know that's another hormone produced by the pituitary. Does HIV affect prolactin levels?
Yeah, prolactin is a bit of a mystery when it comes to HIV. Some studies have shown that prolactin levels can be elevated, while others haven't found that to be the case.
Huh.
So there's still some debate about whether these elevated levels are due to immune dysregulation caused by HIV or if it's something else entirely. It could be that the type of prolactin present in HIV patients isn't very active. More research is definitely needed to figure this one out.
Science marches on. Hopefully they figure that out. Speaking of things that need more research, what about hyponatremia? I know that's low sodium levels in the blood, and it seems like that's more common in AIDS patients who are hospitalized. Is that directly related to HIV, or is that something else?
Well, in many cases, hyponatremia in AIDS patients is attributed to something called SIADH, which stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion.
Yeah, that's a mouthful.
It is a bit of a tongue twister. Basically, what it means is that the body is holding on to too much water, and HIV itself can contribute to this, but certain medications and even lung infections can make the problem worse.
So it's multifactorial. Okay. Let's shift gears a little bit and talk about the somatotropic axis. I know that has to do with growth hormone. Does HIV directly affect growth hormone?
Well, interestingly enough, HIV itself doesn't seem to directly impact growth hormone secretion.
Okay.
However, The way HIV affects the patient's nutritional status and their body composition can definitely play a role.
I see.
And this actually leads to some really interesting differences between what we see in AIDS wasting and HIV-associated lipodystrophy.
Okay, let's break those down. What's happening in AIDS wasting?
In AIDS wasting, patients develop what we call a GH-resistant state.
Okay.
So even though their growth hormone levels might be high, their body isn't responding to it properly.
Interesting.
So as a result, their levels of IGF-1, which is a marker of growth hormone activity, are actually low.
So it's like the body's sending out the signal, but it's not being received.
Yeah, that's a great way to put it.
And what about HIV-associated lipodystrophy? You mentioned that was different.
Right. So in HIV-associated lipodystrophy, the opposite is true. Growth hormone levels are actually reduced.
Yeah.
And this is particularly true in patients who have a lot of visceral fat, which is that fat that surrounds your organs.
Okay. So high growth hormone in one case, low in the other. It seems like HIV is really playing with the body's growth signals.
Yeah, it's definitely a complex and dynamic interplay.
Yeah.
And it doesn't stop there. Even RT itself, while being a lifesaver, can have an impact on pituitary function.
Really? How so?
Well, for one, RT can lead to changes in body composition.
Oh, right, like the redistribution of fat.
Exactly, yeah. And these changes can, in turn, affect how much growth hormone is produced and how the body responds to it.
Okay.
There have also been reports of high prolactin levels and even galactorrhea, which is milk production, in patients taking protease inhibitors, a type of RT drug.
Wow.
And this could be made worse by other medications like certain antidepressants or antipsychotics, and even by opioid use.
Yeah, so a lot of things to keep in mind. So with all this talk about pituitary dysfunction, what does it actually look like for a patient? How do they know if something might be wrong?
Well, the thing is, pituitary dysfunction can show up in a lot of different ways because damage to the anterior pituitary can happen slowly or suddenly, and it could be mild or severe. Plus, it can affect the production of just one hormone, or it can mess with multiple hormones. Some common signs might include fatigue, weight loss, low libido, and even fertility problems.
So those are definitely things that need to be addressed.
Absolutely, yeah. It's really important to get a thorough assessment and individualized treatment, which might include hormone replacement therapy.
Okay, good advice. So let's move on to the other major player in all of this, the adrenal gland.
Okay, that's a good one.
What's happening with the adrenal glands?
So here's where things get really interesting. HIV can cause some pretty distinct changes in how adrenal steroid hormones are metabolized.
Okay, so we're talking about those stress hormones, right?
Exactly, yeah. And one of the hallmarks of this is that we often see elevated basal cortisol levels in HIV-infected patients.
Right, cortisol, the stress hormone.
The one and only.
So I'm guessing that's not necessarily a good thing.
Well, it's not as straightforward as it might seem. Even though their cortisol levels are high, their adrenal glands might not respond as well as they should when they're stimulated by ACTH, which is the hormone that signals the adrenal glands to make cortisol.
So even though they're already producing a lot of cortisol, they can't kick it into high gear when they need to?
That's a great way to put it, yeah.
Oh, that sounds tricky.
It can be, yeah. And this can actually make it more challenging to accurately test for adrenal function in these patients.
That makes sense. So it's possible to get what looks like a normal result on a test, even though the adrenal glands aren't functioning optimally?
Exactly, yeah. That's why it's really important to look at the whole picture, the patient's symptoms, their overall health, other lab values, and not just rely on a single test result.
So context is everything. Okay, so why are cortisol levels often so high in the first place? Is it simply the stress of living with HIV?
Stress definitely plays a role, but there's evidence that other factors are at play as well. Cytokines, for example, those inflammatory molecules that we talked about earlier, they might be directly stimulating the adrenal glands to produce more cortisol.
Oh, interesting.
And in more advanced HIV disease, we sometimes see a blunted response of the pituitary adrenal axis to CRH, which is the hormone that triggers the release of ACTH.
So it's not just a simple stress response, it's more complicated than that. Wow, this is all getting really fascinating, but I have to admit, it is a lot to process. Maybe we should pause here for now and give our listeners a chance to digest everything we've covered so far.
Yeah, that sounds like a good idea. We can pick up our adrenal gland adventure next time and dive into the intricacies of ACTH and testing for adrenal issues.
Stay tuned, everyone. We'll be back soon with more on this exciting topic. Welcome back to our deep dive into the hormonal intricacies of HIV. When we left off, we were talking about the adrenal glands being in overdrive, pumping out cortisol. but high cortisol doesn't always mean everything is okay.
Right. That's right. Sometimes it can actually mask some underlying problems with the adrenal glands. That's what makes testing for adrenal insufficiency so tricky in HIV patients.
You mentioned that the standard ACTH stimulation test, the one where they give a big dose of ACTH to see how the adrenals respond, can be problematic. Can you walk us through that again?
Sure. So basically, the ACTH stimulation test is designed to measure how much cortisol the adrenal glands produce in response to a big dose of ACTH, the hormone that tells them to make cortisol. But if the adrenals are already working overtime because of, say, the cytokine stimulation or the other factors we talked about, giving them this extra ACTH might not cause a huge spike in cortisol levels. It's kind of like trying to hear a whisper in a room full of shouting.
Ah, so the test could come back looking normal, even though the adrenal glands aren't actually functioning as well as they should be.
That's the risk, yeah. And that's why it's so important to look at the whole clinical picture, the patient's symptoms, their overall health, other lab results, and not just rely on this one test.
So what happens if a doctor suspects adrenal insufficiency, even if the ACTH stimulation test is normal? Are there other ways to check?
There are a couple of other tests we can use, but they're not always practical for routine use. One is called the insulin-induced hypoglycemia test.
Oh, okay. That sounds intense.
It can be, yeah. Basically, we give the patient insulin to lower their blood sugar and see how their adrenal glands respond. Normally, when blood sugar drops, the adrenals should pump out cortisol to bring it back up. But if someone has adrenal insufficiency, that cortisol response will be weak or delayed.
So you're basically intentionally stressing the body to see how it reacts.
In a controlled way, yes. But it can be unpleasant for the patient, so it's not something we do lightly. The other option is the meteropone test, which works by blocking an enzyme involved in cortisol production.
Okay.
This basically tricks the body into thinking it doesn't have enough cortisol, which should trigger the pituitary gland to release more ACTH. And if the adrenals are working properly, they'll respond to that ACTH and produce more cortisol precursors.
So it's like a roundabout way of checking the whole feedback loop.
Exactly. But even with these tests, interpreting the results can be tricky. For instance, we have to consider things like hypoalbuminemia, which is low albumin in the blood.
And that's common in HIV patients, right?
It is, yeah. And it can make cortisol readings appear falsely low because albumin helps transport cortisol in the bloodstream.
So someone could look like they have adrenal insufficiency when they actually don't.
Right. It just goes to show that we have to be very careful when interpreting test results and always consider the individual patient's situation.
No, you patients are alike, right? So let's say after all this testing, adrenal insufficiency is confirmed. What happens next?
Well, then we need to figure out if it's primary or secondary adrenal insufficiency.
So primary meaning the problem is with the adrenal glands themselves, and secondary meaning it's a problem with the pituitary gland not sending the right signals.
You got it. To differentiate between the two, we look at ACTH levels. If ACTH is high, it suggests primary adrenal insufficiency, meaning the adrenal glands themselves aren't functioning properly. This can be caused by things that directly damage the adrenal glands, like certain infections. In HIV patients, some common culprits might be tuberculosis, histoplasmosis, or even CMV adrenalitis.
And if ACTH levels are low or normal,
Then it points to secondary adrenal insufficiency. This means the pituitary gland isn't producing enough ACTH to stimulate the adrenal glands. In these cases, we'd want to investigate the pituitary further, usually with an MRI scan, to rule out any structural abnormalities. Unless, of course, there's a known exposure to something that's suppressing the HPA axis.
like some of the medications we talked about earlier.
Exactly. Always have to consider the medications, so things like corticosteroids or magistral acetate can have a big impact on the HPA axis.
So once you know what type of adrenal insufficiency you're dealing with, what's the treatment? Is it different for people with HIV?
The good news is that treating glucocorticoid insufficiency is pretty much the same for people with HIV as it is for those without HIV.
So no special HIV protocols.
Not really. The mainstay of treatment is glucocorticoid replacement therapy, typically with hydrocortisone. We start with the lowest effective dose and adjust it based on the patient's symptoms and how they respond.
Makes sense. What else is important to keep in mind when you're treating adrenal insufficiency?
One really crucial thing to remember is that patients with adrenal insufficiency need higher doses of glucocorticoids during times of stress. Like if they get sick or have surgery, their bodies can't produce that extra cortisol on their own, so we have to give them more.
Oh, right, because their stress response is compromised. What about mineralocorticoid deficiency? Does that come into play as well?
Yeah, so with primary adrenal failure, where the adrenal glands aren't working correctly, you often see mineralocorticoid deficiency too. Mineralocorticoids, like aldosterone, they play a key role in regulating electrolytes, salt and water balance. And when they're deficient, patients can develop electrolyte disturbances.
So things like low sodium or high potassium.
Exactly.
How do you treat that?
We usually give fludrocortisone, which replaces those missing mineralocorticoids and helps get those electrolytes back in balance.
We've really covered a lot of ground here. Any other key takeaways for our listeners on adrenal function testing and treatment?
I think one of the most important things to remember is that even though severe adrenal insufficiency is relatively rare in HIV patients, it can have really serious consequences if it's not caught and treated early. So it's super important to be aware of the potential symptoms. Things like persistent fatigue, unexplained weight loss, low blood pressure, electrolyte problems. If you're experiencing any of those, definitely talk to your doctor.
Early detection is key, right? And I imagine the same goes for pituitary dysfunction.
Absolutely. Another crucial point, and we've touched on this already, is the impact of medications. Medications can have a profound effect on both pituitary and adrenal function. It's something we have to be really mindful of.
Speaking of medications, maybe we should do a quick recap of some of the ones we've talked about that can cause problems.
Sure. We talked about ketoconazole, which is an antifungal medication that can inhibit cortisol production. And rifampin, which is often used to treat tuberculosis, can actually speed up the clearance of cortisol from the body.
And then there's magistral acetate, which is sometimes used to increase appetite in people who are losing weight. That one can suppress both the HPA axis, which controls cortisol, and the HPGA axis, which regulates sex hormones.
Oh,
And abruptly stopping magistral can be dangerous, even trigger an adrenal crisis.
right. And don't forget about opioids, which can also suppress the HPA axis.
Wow, it's a lot to keep track of. It really highlights how even medications that aren't directly targeting the endocrine system can still have significant hormonal effects.
Absolutely. It's all interconnected. Now, on the flip side, there are also medications that can actually help improve hormonal function in people with HIV. ART itself is a great example. By controlling HIV replication, RT can actually help prevent some of these hormonal problems from developing in the first place.
So it's not just about suppressing the virus. It's also about protecting the endocrine system. That's amazing. Are there any other medications that can have a positive impact?
That's a great question, and it brings us to a very interesting topic. A unique type of Cushing's syndrome that can actually be caused by a drug interaction.
Now, that sounds a little paradoxical. We've been talking about cortisol deficiency this whole time, and Cushing's syndrome is all about having too much cortisol, right?
You're exactly right. It seems counterintuitive, but this particular type of Cushing's syndrome, called iatrogenic Cushing's syndrome, is triggered by a specific combination of medications.
Okay, I'm intrigued. Tell me more.
It involves ritonavir, a protease inhibitor used in HIV treatment, and certain inhaled or nasal corticosteroids like fluticasone, which are commonly used for allergies or asthma.
So a fairly common combination.
It can be, yes. What happens is that ritonavir is a very potent inhibitor of certain liver enzymes. Those enzymes normally break down fluticasone. But when ritonavir is in the picture, fluticasone levels can build up significantly in the body.
And that excess fluticasone is what causes the Cushing's syndrome.
Precisely. You start to see the classic signs of Cushing's. Weight gain, particularly around the abdomen and face, thinning of the skin, easy bruising, muscle weakness, and even elevated blood sugar.
But it's not true Cushing syndrome, right? Because it's not the adrenal glands themselves overproducing cortisol.
That's a key distinction. It's what we call iatrogenic Cushing's syndrome, meaning it's caused by a medication, not by a problem with the adrenal glands themselves.
So how do you treat it?
Well, the first step is to identify and address that underlying drug interaction.
So stop the fluticasone.
That's one option. Or we could switch to a different corticosteroid that isn't as affected by ritonavir. Sometimes we might be able to adjust the ritonavir dose, but we have to balance that carefully against the needs of the patient's HIV treatment.
Right. And I'm guessing you have to taper the fluticasone slowly
Right.
to avoid triggering an adrenal crisis.
Exactly. You're absolutely right. Abruptly stopping the fluticasone in this scenario can be very dangerous because the body's own cortisol production has been suppressed.
So you have to gradually wean the body back onto its own cortisol production.
Precisely. It's a delicate process.
Wow, this whole medication situation really is a minefield. Are there any other drug interactions we should be aware of?
A couple more, yeah. Budesonide and triamcinolone, which are also inhaled or injected corticosteroids, can also cause iatrogenic Cushing's syndrome when combined with ritonavir. though it's not as common as with fluticasone.
And the same precautions apply, I assume. Tapering slowly and monitoring closely.
Absolutely. And to make things even trickier, this iatrogenic Cushing syndrome can be especially difficult to recognize in people with HIV who already have lipodystrophy.
Right, because they already have changes in their body fat distribution, so
Right.
you could easily mistake one for the other. It really is all about paying attention to the details.
It is.
Well, I think we've covered an incredible amount of information about adrenal function testing, treatment, and some pretty mind-boggling medication interactions. Anything else you'd like to emphasize before we wrap up this part of our deep dive?
Just a reminder that everything we've talked about today is for informational purposes only.
This is not medical advice.
Exactly. If you have any concerns about your hormones or anything else we've discussed, please talk to your healthcare provider. They're the best resource to help you figure out what's going on and come up with the best treatment plan for you.
Couldn't agree more. Now, ready to move on to the grand finale of our hormonal deep dive.
Let's do it.
In part 3, we're going to shift gears a bit and explore a thought-provoking question about the future of endocrine care for people with HIV. You won't want to miss it. And we're back for the final part of our deep dive into HIV and hormones. We've covered a lot of ground, from how HIV affects the pituitary and adrenal glands to the challenges of testing and treating hormonal imbalances to those crazy medication interactions. It's been a wild ride.
It really has.
But it's amazing to see how much progress has been made in HIV care. I mean, back in the early days of the epidemic, it was all about managing those opportunistic infections and those severe complications. Now, thanks to RT, people with HIV are living longer, healthier lives. It's pretty incredible.
It really is a true testament to the power of science. But, this increased lifespan brings a whole new set of challenges, especially when we start thinking about the long-term impact of HIV and its treatment on hormonal health.
It's like we've conquered one mountain, but now there's an even bigger one looming in the distance.
That's a great way to put it. And it leads us to a really crucial question. With this growing population of people who are living long-term with HIV, what are the new research areas that we need to be focusing on? What needs to be done to ensure that these folks continue to thrive?
That's a big question. Where do we even start?
Well, one area that I think deserves more attention is the interplay between those age-related hormonal changes and HIV.
So on top of everything else we've talked about, we now need to factor in the normal hormonal shifts that happen as people get older.
Exactly. We already know that as we age, our hormone levels naturally decline. Things like testosterone, estrogen, growth hormone. But we don't really know how these age-related changes might be different or perhaps accelerated in people who are aging with HIV.
So is it possible that having HIV could make those age-related declines happen faster or more dramatically?
That's one of the key questions the researchers are looking into. And another really important area of research is understanding how those hormonal shifts might contribute to other health problems that become more common as we age. Things like heart disease, bone loss, cognitive decline.
Right, so it's not just about treating the hormone deficiencies themselves, it's about the bigger picture. How do they affect overall health and quality of life as people with HIV grow older?
Exactly. That's the key. And of course, another critical area of research is looking at the long-term safety and effectiveness of hormone replacement therapy in people with HIV.
Because they might be on these therapies for decades.
Potentially, yes.
Yeah.
And we need to make sure those therapies are both effective in addressing those hormonal issues, but also safe for long-term use.
Are there any specific safety concerns?
Well, like any medication, hormone therapies can have side effects. Plus, we always have to think about potential interactions with other medications. People with HIV are often taking multiple drugs, including their antiretrovirals, and we need to make sure those aren't going to clash with any hormone therapies.
It's that whole web of interactions again. It sounds like there's a real need for more personalized approaches to hormone care for people with HIV.
Absolutely. We can't just take a one-size-fits-all approach. Treatment strategies need to be tailored to each person's individual needs and circumstances.
Makes sense. Are there any other research areas on the horizon that you're particularly excited about?
There is one that's particularly fascinating to me, and that's the role of the microbiome in hormonal health.
Wait, the microbiome? Those trillions of bacteria that live in our gut?
The very same.
What do they have to do with hormones?
More than you might think. There's this growing body of research suggesting that the gut microbiome can actually influence hormone production, metabolism, and even signaling.
Wow, I had no idea. So researchers are looking into whether disruptions in the gut microbiome could be contributing to some of the hormonal problems we see in people with HIV.
Exactly. And if there is a connection, Could we potentially target the microbiome to improve hormonal health, maybe through dietary changes or probiotics?
Now, that would be incredible, almost like a natural way to address these issues.
It's definitely a promising area, and the implications could extend far beyond HIV. It could be relevant to hormonal health in everyone.
Well, I think we've given our listeners a lot to think about today. Any final thoughts you want to leave us with?
Just a reminder that we've only scratched the surface of this complex relationship between HIV and the endocrine system. There's still so much to learn. But with continued research and a focus on personalized care, we can really help people with HIV live long, healthy lives in hormonal balance.
Couldn't have said it better myself. A huge thank you to you for sharing your incredible expertise with us today. And to our listeners, we hope you found this deep dive informative and thought-provoking. Knowledge is power, so stay curious, keep learning, and be your own advocate for your health. We'll see you next time for another fascinating deep dive.